to your other point of, needing that diversity of skills, even if it's just in sort of speaking a different language, even if it's just like the metaphor of being like multilingual,
Right.
yeah, important to kind of not chameleon, not to take the concept that far, but
Mhm.
absolutely to see patient care as customer service,
Right.
not as any kind of negative connotation, but a very positive connotation.
Right.
I had a patient who, it's funny you say that, I had a patient who came into the office with some true hip, growing pain. And she had seen like 50 different people,
Mhm.
they'd done all these pictures of this, that, and the next thing, plenty of imaging tests, plenty of different flavors of specialists, so like, there are things where I feel good about the education I've sought, but my ego is not so big that I think I'm going to like house MD her hip suddenly. And like, oh,
Mhm.
it's the 51st biomedical diagnosis. There's 50
Yeah.
wrong. But in order to gain that trust, I'd seen her a few times, and I very slowly went through some of the pain signs and maybe a little bit of what's going on and why she had gotten 49 different diagnoses from 51 different guys. You know what I mean?
Right.
But the thing that eventually allowed some level of trust to form was doing like a very specific joint by joint functional evaluation, right? Like just each little inventory of, and it was sort of a moment of like, look, I'm not playing their game, but if I did
Mhm.
play their game, now I know exactly what's going. You know what I mean? Like I
Yeah.
know the game they're playing. And
Right.
I even said too, just because of kind of knowing. I've been in the game a few years and just kind of seeing like patterns. You know what I mean? Even in
Mhm.
the beginning, I was like, okay, anyone ever look at your ankle? Nobody looked at your ankle. Okay, so I know, like in my head, we're probably gonna find something at the ankle. You know what I mean? And so I go through and I go, okay, here we go. It's nobody ever, we found such and such in your ankle. So here's the plan. And it's back to your earlier point. If I'm not lying to anyone, but it's like I found these opportunities to introduce noise in the system, right? Like I
Mhm.
found these areas where we can create a change, and lo and behold, now like kind of having proven like I'm saying this other thing, but I know their thing too. Like
Right.
you can feel good that I know both languages. I'm choosing to
Yeah.
speak this one, but I know what they are saying too,
Right.
and it goes a long way.
Yeah. And I think what's really important there when you have the chronic patient or client that has a lot of history with other healthcare practitioners is that you toe the line between appreciating where they're coming from and their frustration, but also not shitting on any of the
Yes.
previous care that they've gotten, and just making it something different that you're
Yeah.
doing, right? Like and understanding what hasn't worked for them in the past, what they also are coming in thinking that they still need, right? Because it's sometimes you can get to the point where you have that many diagnoses and you don't think that there's anything else. You're very skeptical of anything else. So
Yes.
you have to present what you're doing as different, but not say that, well, everything in the past was terrible for you, and well, now
Right.
I'm going to be this savior. It's just looking at it and trying to explain why it might be difficult to actually get a solid diagnosis, I think is useful in those cases. Not saying that all of the diagnoses were wrong or right, just being that like diagnosis in general is a hard thing especially when we're looking at trying to create movement changes, right? So the more specific anatomical diagnoses you get, like we can like say that you have a lack of ankle range of motion or a lack of hip range of motion, and that could become a diagnosis for somebody, right? And it happens all the time. Or it could just be like, okay, that's part of like whether you have pain or not, that could be very normal, but this is something that we can see if we try to free you up here, because this isn't something that's been attempted before. Does it allow for more ease of movement. And then there's going to be more of that we find throughout your body, so that it starts to gear people away from the idea that there is a right diagnosis out there, and more towards all right, now we're in a process that's going to be ongoing, right?
Mm-hmm.
But that process can actually get me moving in the right direction, not just like in a constant search. And
right.
I think that's a slippery slope, but that is an important thing to be able to get people to switch gears, especially when they're coming in with all these diagnoses. So it's like, I try not to ever talk poorly about somebody that they've seen in the past or some other diagnosis, but I do try to just kind of switch gears out of the idea of diagnosis, and we're looking at diagnosis from a different standpoint. And especially as a therapist, I'll just be like, what I do as a physical therapist really has very little to do with MRIs, has very little to do with X-rays, has very little to do with these diagnoses. It just has to do with how you're presenting in front of me each day. And then just trying to go from there.
Well, that is such a very careful game for sure. And again, like that's, I was trying to, again, we've done, MRIs, you've seen orthos, you've seen specialists, and so, try to come in here and go, I'm 51 guys didn't miss, 51 guys didn't do a bad job, of approaching it. The tact I tried to take then was to say, look, we don't need to justify your pain with a broken bone, let's say, in order to make it meaningful. Like that's kind of the angle I tried to, it is meaningful because it sucks. And
that's very well said. Yeah.
You're suffering. Yeah. Right.
Yeah. I think that's a great point. And I think that, it kind of like brings it all together. Is just, whether chiropractor, physical therapist, like whoever's dealing with people in pain, like we do have to just make it more patient centered. Right. But that, what that means for our education is that we just want to be open to getting as many different viewpoints as we can. And we want to be able to look at things through the patient's eyes, which is not an experienced practitioner. Right. So if you've gotten the most, up-to-date methodology in your head, well, that's not that useful sometimes for your patients, unless it's able to incorporate other things, right? Like unless it's able to be a very coherent methodology, right? So anything new you learn, you have to be able to take it to, all right, how am I going to be able to make this meaningful for a client, right? And be able to get them to be interested in it, right? And so that's going to be just, that makes our learning process more of a process too. Just like we were talking about, like patients looking at curative type of measures. A lot of times I think professionals look for the model to end all models. Right? Like we found the movement model that now I don't have to learn anymore. It's just as long as I really understand this, I don't have to like look for anything else, which I just don't think that exists. I think we want to just appreciate it all, which means that we have to find what's common more than what's different in how we learn.
Right. For sure. And you just made me have like a little bit of revelation here in my head. And that is that, you're right in that, patients don't know what we know, but patients haven't had the experience that we've had.
Right.
And so to your point of like knowing all the different schools of thought and approaches, like you were making me remember that do you know who John Sarno is?
Yeah.
Okay. When I first started chiropractic school, somehow I came across one of John Sarno's books. And, certainly he adds a little bit of like anthropomorphizing the experience of pain, you know what I mean? Like he I think he adds a little bit more motivation and subconscious to the concept of pain that is really there. But like, I feel like in the 80s, there's a extent to which he was sort of the least wrong. You know what I mean? Again, this minimizing ignorance, because he was like, definitely a connection between what's going on in your life and your pain. And he was, like that in the 80s. Like, I feel like that was certainly, he must have been one of only a few public sort of docs putting out that kind of info. But anyway, so I read this thing, and in my head I'm like, wow, this is the stupidest thing I've ever read. Because in my head I'm like, Occam's razor. There are, beginning of chiropractic school, there are pain receptors, there's pain pathways, we have a nervous system, like Occam's razor. Dude, you're making 100 philosophical assumptions that don't need to be, and it wasn't this idea of even with knowledge. It was instead the experience of living and observing. Like, these guys did the exact opposite things. These two schools of thought literally contradict each other, and they both did it in the same case, and they both got good results. Like, it wasn't until having those experiences that I'm like, oh, wait a minute, Occam's razor, context, like that kind of thing. But it doesn't matter how much encyclopedia knowledge I had. It's an interesting standpoint. Like, patients haven't experienced what you've experienced, and that's an important thing to consider. Anything I've read from Sarno, one of the things that was evident was that what he's saying, it fits very much with like the current biopsychosocial model, as far as that it does matter, like your emotional situation and other things that go outside of like specific physiology that we would normally look at from a musculoskeletal standpoint or a neuromusculoskeletal standpoint. But I think it was probably just either a sign of the times, or it was just like he needed to kind of market it as something. He put a pretty specific diagnosis on what he was talking about as like, and that it had to do with the muscle not getting enough, like there was like a hypoxia going on within the muscle. So as he tried to over-specify, I think, what he was saying from a physiological standpoint, and then he also started to say that he no longer felt that he needed to refer anybody out for physical therapy and things like that. So like, it just, that it was just taken farther than it needed to, right? In many ways, because it became like, this is what's going on now. Like, he took something that had this sort of more open-minded approach at, look beyond just the kind of musculoskeletal system, look at the whole human organism. But then he overspecified it to saying like, none of that stuff matters anymore in a way. You know what I mean? Where I just thought that was problematic, and maybe that was, again, marketing. Maybe it was just like he had to put a diagnosis on it because he was coming from a world of physicians that they put their own diagnoses on it. So he was just kind of adding this into the mix. But either way, I think it became, from what I read, it was actually less inclusive over time because it got too specific again. So it's certainly, you can see how it would be useful. Like all the people that, got better and claimed to get better through that mindset, you could see how that would absolutely fit into what seems to be beneficial from a biopsychosocial model of treatment, just educating patients, having patients, appreciate that their life situation really matters with their pain. But then to, again, try to go into too much specific detail about like what exactly is causing the pain, I think it starts to be problematic. There's I feel like there's and not to be too silly with this, but there's almost like a poetic, theme here, which is that he comes along, he's got something new, he's open-minded, he's exploring new ideas, right? And it's like, well, this is the idea now. Now that we've solved that problem, But
and I'm sure, sure that happens with a lot of these continuing education models that we go to, where it's clinicians like you and I that, as we're experimenting in the clinic, we find things that work, and then we have to put some type of system behind it. And if we want to then turn it into a continuing education process, then we have to write it down. We have to make it very structured. We have to make sure we have some type of, source evidence behind what we're saying. But then it also is going to become something, if it becomes successful, that you have to back up, your claims from, the masses, like kind of attacking them. And you probably get a bit defensive with that. And then you probably actually get more, like you hold on to your precious model more, and it can help, probably makes you a little less open-minded to other things. And that's always one of the things now that tends to turn me off the most when I go to continuing ed courses, even courses that, like, I know the material is useful. Like, I use it all the time. I love it. It's really changed my mindset around treatment. But when I get the instructors that are shitting on other models to promote their model, it's just like, all right, you lose me there. You know what I mean? And it's just, I think in the long run, it's not useful, but I get why it likely happens. And it's probably almost becomes a subconscious thing, because it's like you're defending your flag.
Right. Well, I think some of it too is sort of a victim of their own success kind of thing, where, like, I feel like, and again, this is not, crapping on anybody, shitting on anybody. It's more like pointing out their successes of like an ART or a McKenzie, where, McKenzie has this really good, system based on patient response. But I remember looking at the McKenzie outline and like, well, wait, because their concept is you're moving the disc fluid. That's their idea. Like, well, what's lower extremity doing on here? What's upper extremity? It's like, well, we got to codify it. We have to have our version of, same thing with ART. Like ART had, upper spinal, lower, and then, there's an extremities course. There's a nerve course now. There's, recurrent motion. We're doing the boat, like, okay. For codifying, you had a great idea. Stop codifying for every,
So what my experience with McKenzie, and this actually was very helpful for me coming out of school, because that was like the first continuing ed process I went through, just to understand that, like, the base kind of marketing material that you get from the outside looking in at some of these models is not accurate. So, like, for instance, you go to PT school, what you learn about McKenzie isn't even promoted by the actual McKenzie method itself when you take the courses. So the first course I took for McKenzie, it was like they addressed the disc model, and they basically just said it's a theoretical model that doesn't need to be true for this to be useful. And it basically went into what we were discussing today about how you're going to meet the patient where they are. So if they have, like, this idea that something is going on within their body, and they need to know kind of, why is this useful, what I'm doing, you can paint the possibility of this model of moving the nucleus of the disc. But if you get too specific with that, that could easily be refuted by, biomechanical research when you start looking in the body and things like that. However, the responses that are promoted by repeated motion assessments, centralization, peripheralization, like all of these things that have really no bearing on whether a disc is moving or not. If they're happening, they tend to lead to better outcomes. So ultimately, what the McKenzie model, and I still use it, but I find it, like, super valuable because it's pretty simple, as this idea of symptom response trumps all for physical therapists. At least it should, more than what we think is we are doing to the underlying structures. Right, because that is the more global thing that actually matters, and then we can have an idea of why it's happening. But, like, it does. We don't really need to know specifically. We just need to be able to be flexible enough, and we need to study, like, behavior or symptomatic response that is consistent. So that leads to these patterns, right? Which we do have. We have these treatment-based classifications, which are pretty well studied. That if you get centralization of symptoms, it's a good thing, right? If you get peripheralization of symptoms, it's a bad thing. And that can happen at other joints, though. That's the reality. So that's why, like, it's not that useful to have these specific anatomical, because then you can't generalize to other joints. But if you just take it as symptomatic response, you can. And that's what I think that's what McKenzie has done, where I remember when they started talking about taking it into extremity courses, asking the instructor, like, well, yeah, what's happening at the elbow? What's happening at the knee? And they, I remember the guy came up with, like, some possibility. It was like meniscoids and things like that. And it was just like, okay, like, because the model has the three categories or archetypes. There's derangement, dysfunction, and postural. right? So derangement is the one that we think about mostly with McKenzie, where it's like the disc model, where, you know, if you extend, you're pushing the disc back in because the disc nucleus is deranging the joint, right? It's like, so anything that is getting in the way of a joint moving and at the kind of opposite direction, like repositions it, would be the thought, but it really just like makes things better by going in the opposite direction with repeated motion. That would be like a derangement, and that there's a rapid change. So like a dysfunction would be more just like you have shortened tissue and you actually have to move into the pain because you have to remodel the tissue. So all of these things are, you know, like how you choose to describe them. Like, are you really remodeling tissue by going into it over and over again? But if your range of motion improves and the pain is pretty stable, where you touch it as soon as you take the direction, or you take the movement that provoked the symptom away, it goes away, and that becomes the process that you see over and over again. And as you do that more, you see increased range of motion. That would be considered dysfunction. Why that's happening doesn't really matter, but you have, you know, again, you have these models of saying, okay, well, that's remodeling tissue, where you have the derangement model that says I'm repositioning something, or I'm knocking a block of the joint out of the way by doing this direction. Like, that's the more broad you can be with it, the better. But that's ultimately what we're doing, is we're creating these movement models based on symptomatic presentation. And it can just be that. It doesn't need to be any deeper, right? Because if that's what's consistent, that's what's going to lead our treatment, and that's what's going to lead people to get better.
Right, which goes back again to, we don't need to justify your pain with X, Y, Z. Your pain is meaningful because it's your pain. Like, we're allowed to start there, and to kind of take this sort of full circle back to what you were saying about using some of, you know, the terminology, the explanations the patient comes in with. You know, if they've already put some level of identity, if they've already put some level of faith into the practice of, we're going to fix posture, we're going to, you know, change a curve, we're going to heal up a disc, whatever it may be. You're like, that is why I like that concept of the bucket of water, right? Because then that allows us to go like, that's part of it. I will affirm that. That's part of it. You know, but there's all these other things that go into the bucket, you know, and it allows you to take this thing and go, you've used this as something that helps you because you have faith in it. Cool. Now we can steer into that positive effect without, making it like that's the thing, right? So I want you to keep using that tool. Also, let's talk about some of these other things that go into the bucket.
Right.
And I think there's a flip side of that, where what I'm referring to is like, hey, don't get too hopped up on the postural thing. It's not the be all end all. But what comes to my mind is, I've been sifting a little more diligently through some of the clinical athlete forums lately. And there was some really great discussion there about how the evidence has not really alluded to. It really hasn't revealed this dependence that forms on manual therapy. Like, manual therapy is not, the evidence is not there that like it's eroding patient autonomy, you know. And so it becomes this other, like, it becomes the bucket for me of like, I mean, don't vilify this thing, right? Like, don't worry about it. Let that go into the bucket. Like, don't keep that out of the bucket. You know, all just again, it's just it's listening to the patient, acknowledging they've already got this tool. All right, man, we'll go with the tool. Flow with that.
Right. Yeah. I think that's a good point. The last piece I think I'll add to that is I think the same thing. I just wrote a blog about like self massage, basically, like any type of like foam rolling and working on yourself. I think the same thing happens there that happens with manual therapy, where you can see different studies that maybe pick apart the individual theories of what's going on there and say that, okay, this isn't happening, right? Like, we're not, reducing cellulite, which is, we're not like breaking up scar tissue. And then it just, you have a lot of clinicians, especially, that will just say, oh, okay, well, this is nonsense. I mean, like, I'm not even going to touch it. I'm not even going to look at it. instead of appreciating that, like, people were doing it for a reason, right? Like, it just doesn't come out of nowhere. You know, it's not like somebody's just like at home saying, you know, I'm going to make money off of this. No, like, you make money off of it because people were already finding some benefit. Right. You know what I mean? And then you kind of, I think, spin the theory behind what goes on there. But there's some benefit that you can use. You could use it as a tool in your ever expanding toolbox as a clinician. So I think it's our job, and what I try to do in the blog post, I actually wrote 2 blog posts because there were, you know, different places where I thought it would be more appropriate to talk about different things. Just talking about all the other possibilities that might be there that are beneficial, from foam rolling, from using a ball in certain areas. And you can think about many. I think I put like 6 or something in the 2 blog posts, but it's just like that concept of saying, okay, like, there's the broad technique, and then there's all the other things that you try to say are happening that you're sort of just guessing are happening. But like, if one of them gets, you know, disproven through science, that doesn't mean the technique as a whole is useless, right? So, and you know, it happens with manual therapy all the time. But then people will come up with different ideas of why it actually might be harmful, right? And then, like, so with manual therapy, it's become like, well, people will get addicted to it. And then you hear it enough times, you think it's true, and then you realize that there's no evidence behind it, right? And I think that the same thing happens with a lot of different movements. And, you know, well, if you have bad knees, you shouldn't squat. Well, you know, there's no evidence. Sometimes there's evidence to refute it, but, you know, you hear it enough times, it just becomes like, it's like an old wives' tale. It becomes the truth until you actually have somebody explain it to you different. But I think when you explain it, you have to meet people where they are, for one thing, but you have to have a lot of different ways to understand the same category, right? So manual therapy should be this very broad term, right? Mm-hmm. That you can use for many, many different reasons. And by having more ways to describe something, you can fit it into more people's presentation, right? So then it becomes more useful. And it's also harder to refute that it's not useful, because you can refute like one specific claim, but again, the more broad the category is, the more you can be flexible as a clinician.
Yeah, man, I like it. It comes down to not taking your own tool seriously, which we, you know, and you know, have a lot of explanations, have a lot of tools for everybody. I like it. Yeah.